This is one of my favorite lectures. I have to fully disclose, I started off in orthopedics. Can you tell? And then I switched over to do primary care. And then I practiced as a primary care physician for about 4 or 5 years. And then I did emergency medicine after that. So I get to do fun and interesting joint reduction. So that's why this is one of my favorite lectures to give, because it's always about putting the joints and the bones back where they belong. And isn't there great satisfaction? Like, don't you just love it? It's like, oh, that shoulder slides back in and you are like, yes! Except for when it doesn't, and then you feel great shame. So we're going to talk about some interesting joint reductions. So yeah, it's wonderful when it's successful. We want to give you maybe a few techniques, a few ideas, a few hints on how you can be even more successful more of the time with these reductions. And so you don't have that failure of shame. Reductions is all about time and pressure. It's not about force and strength. It's about proper sedation, and that sedation might be just Jedi mind tricks, and I'm going to show you some Jedi mind tricks. One of them is called the Cunningham method. And I don't know if you're familiar with that, but they will think you are like the amazing Kresge putting in a shoulder with no sedation, just massaging the trapezius muscles, looking deeply into their eyes sympathetically, some gentle traction, some external rotation, and there's the win. And it actually happens just like that. But it takes time and the appropriate amount of relaxation. So time and relaxation. It's not the jerk. If you walk into a room and you see someone doing like putting a shoulder back in and they're just like, that is the wrong technique. Okay? It's not about sudden motions with great force. Sometimes you have to sedate them. Sometimes you just have to relax them. All right? So here we go. Jim just gave you that mandible, that jaw reduction. So this is a great segue and some spaced repetition right here. If somebody comes in with a dislocated jaw, I will show you one of the techniques and maybe the best way to approach the person with this technique, and then something that the patient themselves can control it. So it's very patient-centered. So often it's like the boot camp course, and yeah, I went out for a big lunch at that Wolfgang guy area, and those burgers are fantastic. Is it Wolfgang that has the burgers? Oh man, they are good, and they are big, right? And so you give this big yawn, and you pop your jaw, and you're stuck like this, and they come in and they're drooling, right? And you go, oh, what's wrong with them? Just like Jim had that case. What's wrong with them? They're like this, and they're drooling all over the place, right? So how do you put that back in? So the classic technique is to wrap up your thumbs with gauze, because you are going to put them in their mouth and you're going to try to overcome that spasm, that trismus, and push down. If you approach someone from the front, right, and put your hands in their mouth, a lot of the motion has to come from your wrist and elbows, and it takes a lot of strength, right? And those jaw muscles are stronger than my wrist muscles, and when they snap back in, they can bite down on these. And so one of the ways you can do it is come and approach from behind. And you get behind the patient. You have them sitting, right? And sometimes, depending on your height, you might need one of those CPR step stools. And you get up on there, and then you can have straight arms and lock the elbows. And you know what you can do? You just lean in, right? And you just lean in and use your body weight, and you push down. And it's time and pressure. But it's not sudden motion, and you just lean in, and it'll pop right back in. That's one of the nicest ways to do it. So you can give them a little bit of Versed. Now, depending on your documentation requirements at your hospital, you are using the 5 milligrams of Versed IM. You're not doing procedural sedation. We know you're not doing conscious sedation, because that's an oxymoron. You're not doing procedural sedation. You are giving them some muscle relaxation. You were addressing pain, but you were not doing procedural sedation. And just a little bit of Versed, a little bit of 5 milligrams of midazolam, IM, go see another patient, and come back, and they're ready, right? And then that's very light, and you just approach from behind, put your thumbs in your mouth, and lean over with locked elbows. And it's that pressure, that steady pressure. Now, there's a few other techniques that you can do. This is the syringe technique. And this was published in the Journal of Emergency Medicine 4 years ago. Small study, 31 people. They had a 97% success rate. And what you do is you put a 5 cc or a 10 cc syringe in their jaw, like in their mouth, and you have them bite down. And you just tell them to bite down. Within 1 minute, 77%. Within 1 minute, 77%, now out of 31 patients, had relocated their own jaw. Right? And so you don't even have to put your fingers in their mouth. Now, I did talk to the billing people. Apparently, you can bill for that too. Good, somebody get to the joke. So yeah, it's a reduction, right? And so you can reduce the jaw that way. But you just put the 5 or 10 cc syringe in there. Another way I've heard about is you get a stack of tongue depressors, and you give them about 5, and then you give them a few more. And you say every 30 seconds to about a minute that you can tolerate, slide another one in. And it's that slow, steady pressure. You go and you see another patient, and you know what usually happens? The patient's standing there at the front of the room going, yeah, what do you want me to do with these now? And they've reduced it on their own by just slowly sliding one more tongue depressor in. And after 2 or 3 minutes, they've relocated their jaw themselves. All right, sternal dislocations. Don't see this too often, but it can come from a direct blow. So you can imagine a direct blow to the anterior chest, and you get that sternum and the clavicle dislocating posterior from a direct blow, but they can also dislocate anterior. And both can be reduced with the same technique. So if you get a direct blow to your anterior chest that's this high, that's addressing your sternum and your clavicle, there's a few things that you might also want to be worried about. So you might want to fix the sternum and the clavicle later if they're like, because there's an airway there, right? Also, there's a neurovascular bundle that's reasonably important in the anterior part of the chest or the anterior part of the neck, right? And so you might have to address those issues first, but if somebody has a direct blow, think, oh, could this obstruct their airway? Could this impact in their vascular system? Get a CT scan. All right, it's got down there, we do closed reduction, and it's got towel clip question mark. And I'll explain how the towel clip that you can use comes into this. So sometimes you need a few extra views to get a good idea. And so if you have a palpable lump anterior, that's a good idea that it's an anterior dislocation. And you can get a serendipity view or a Hobbs view. And so they show a true lateral there, and then they show the serendipity view. And so here's you've got the serendipity view that you can see, and you know you can see those clavicles are not lining up on the sternum. They're not pointing towards each other. One's higher and one's lower. So you've got a dislocated clavicular sternal joint. How do you put that back in? Well, first you push down on the shoulder, okay? And so that's A. You push down on the shoulder while the patient is lying on the gurney, all right? And then you take the arm and you externally rotate and pull a bit. And that can pop it back in. Now, there may be an associated fracture to get such a high dislocation. And so imaging helps, right? So you may have a fracture dislocation. But if it doesn't work, what you can do is you put the person in that 0 position, right? 0 is here. And you put traction on it. And if it's not coming, you can anesthetize this area and put a towel clip and lift. And get it to pop in. Okay? I've never had to go to the towel clip. Never had to go to the towel clip. But you don't want to just put the towel clip on. Right, without anesthetizing it. Local anesthetic, 1 to 2% lidocaine, which is 10 to 20 milligrams per mil, right? All right, let's go to something more common though. Okay, so we see shoulder dislocations, but you can have a little bit of a variety of shoulder dislocations. Not all of them, most of them come in as an anterior shoulder dislocation. It's easy to recognize that individual. They come in going, right? It's usually someone with a Y chromosome. I'm allowed to say that, right? Okay, good. And they're holding the arm because they're holding it still. They'll either have it down like this or they're holding it like this, and you've got that nice little sulk sign there. Sulk sign. So, but you can get posterior dislocations, and they can be bilateral. And you can see this is the classic example of getting bilateral shoulder dislocations, is if you get electrocuted, or if you're in status epilepticus. And so you can seize so strongly that you put both shoulders out. Jim here, of course, intubates you for the, was it an INH overdose? Intubates you and then gets transported up to the thing. And you've checked the film, you know, that tube is in place, right? But both shoulders are out. And then when the patient wakes up 3 or 4 days later and they're extubated and their shoulders are like, I can't move my arms. Okay, so posterior dislocation. So if you have someone in status epilepticus, which you're intubating, don't just look for tube placement, take a look at those shoulders as well. If they look symmetrical, they may be symmetrically out. All right? And then luxatio erecta, it sounds like a Viagra overdose, but it's actually an anterior shoulder dislocation with your arm in this position. And so the patient comes in like this. Hey, how you doing? High five. High five. Yeah. You go, yeah, high five, put your arm down. No, they can't. No, put your arm down. And they can't. So the shoulder's out anteriorly, but up like this. All right, now it can be posterior. That's really, really rare. In fact, I haven't seen that, but I have seen anterior like this. The nice thing is, you can relocate them pretty much the same way. All right, so scapular rotation. This is one way you can look like a Jedi master putting the shoulder back in. All right, and you don't have to go with procedural sedation. You can just give them 5 milligrams of midazolam, go off, see another patient, and come back. And with scapular rotation, you posteriorly just rotate towards the spine, midline, that scapula. Now, I didn't have a lot of success with this maneuver until I figured out that it helps if you have someone actually bracing the anterior portion of their chest while you're moving that scapula around, and it'll just pop back in. And sometimes you can do that on the ambulance stretcher if they come in like that, right? You just go, okay, and you get the paramedic to put their hand there, and you just go, okay, no, I'm just going to examine you here, yep, looking good. Oh, yeah, you're a little tight there. I feel the spasm. You talk them through it, right? And then bump, and you're like, for the win. Now, if it's a traumatic, so it's not just the tall, skinny kid going up to rebound the basketball, pops it out. I mean, this is the most vulnerable position you have for your shoulder, up like this. And if they're a repeat dislocator, again, you don't necessarily need the x-ray. And the concern always is, what happens if they have a fracture, right? A fracture dislocation. If they give a story of doing stuff like this, right, it's not a fracture dislocation. If it's an LOL that falls, I'm worried. Thin bones, osteoporotic, okay. Now, Greg Henry might tell you it's not necessary and it doesn't necessarily help you to get a pre-reduction film. Because if you've reduced the thing, the shoulder, and it has a fracture, when you get the post-reduction film, when did that fracture happen? Oh, I don't know. We don't have a pre-reduction film. Right? It could have been fractured already, right? So if you get a pre-reduction film that shows no fracture, and then your post-reduction film shows a fracture, guess who did it? Right? And so sometimes having the pre-reduction film is not helpful, and people think it protects them medically, legally. Not necessarily so. So if they give a good story and there's not a lot of trauma involved, or they're a repeat offender for dislocation, I don't get the pre-reduction film. I just put that scapula and do that scapular rotation. You got to check for the nerves, right? And we went through a little bit of the hand stuff today, but the axillary nerve, the fifth, right, C5, is right here. So you just rub them on the deltoid. If you want to know 6, that's 6, C6. It's right there, see, C6. This is 7, and, sorry. We're being recorded, aren't we? Sorry about that. And this is 8, right? This is C8, C7, C6, right here for sensation, C5. All right. So scapular rotation, yeah, there's the picture of it. So I'm there in the back, right? And you can just rotate that scapula around, and you get someone in the front to brace, right? And they can put a little gentle traction on the arm and then brace the shoulder, and you rotate that scapula around. And you don't need to do procedural sedation for that. All right, so there's lots of different ways to put a shoulder in. I would recommend that you get really familiar with a couple of them, so you have a plan A, maybe a plan B and C. And I'd ask you not to do a few of them as well, because a few of them are dangerous, high risk for neurovascular injury. Okay, so I'm going to show you a couple of the ones that I like to use that don't have neurovascular injury associated with it, and I don't think you should use that method. but just get comfortable with. So I've shown you that scapular rotation. We've got down there about a 50%. I'd say that's reasonable, about 50% of the time, get that back in. But the Cunningham method, I really like that now, and I'll show you what that looks like. And then there's the Syringe Technique, and that's with the arm held out straight. The patient's lying prone on the bed, and the person's pulling and externally rotating that shoulder back in. The shoulder wants to go back in. It really does. You just have to relax the patient enough and show them the way. Another way you can do it that's not shown here is where you can tie the weight around the wrist and have the patient lie on their chest, and the arm is hanging over, so they're lying on their chest, their arm's hanging over. Give them 5 of midazolam, walk away, right? They can't be holding it, because if you hold the weight, right, you clench up in your shoulder girdle, right? You just let that stretch out, and you'll come back, and they'll be like, yeah, it's in, right? Holding the weight, right? It's just time and constant, steady pressure with appropriate relaxation. So here's Dr. Neil Cunningham. He designed this. And so you face the patient, and it's your right arm and their right arm, right? But you're facing them, right? And you put your left arm up on their trapezius, and you just talk to them, massage that, get that shoulder to relax. And what you do is you're slowly, while their arm is up here, you're slowly pushing down a little bit, and then you're sitting on a wheeled chair, and you slowly rotate out and do external rotation like he's sitting there in that second black and white shot. And I've had great success with this. I've had people coming in like, I'm so scared, or they're so panicky, or I don't want opioids, I've been addicted, or something. Like they just absolutely do not want to be put out or something like that. That's okay. We'll just sit down and talk about it. And you're really tense up there. I'm gonna try to put this back in without the medication. Maybe give you something to relax. You massage up in the trapezius. At the break, I can show you how to do this, okay? Because it's a bit of a hands-on thing when you need to demonstrate it. It's hard to pick up with just the pictures, but I've had great success with this. And there are some different methods that you can use and the different success rates. Just find a couple that you feel real comfortable. I've seen people just tie bed sheets around their waist, right? And have the elbow and the sheet around the elbow like that, and have the elbow flex, and then they just rock back and roll forward, like that externally rotates their arm. And sometimes you have the second person with a sheet around the patient's chest to have a little bit of gentle countertraction. So come up with 1, 2, 3 techniques that you feel really comfortable with that are low risk for causing injury. Here are some high risk for injuries, and you should not be using it. I'm only going to describe 2 of them because the Coker method, I don't want you to learn these. But from a historical standpoint, Hippocrates, the Hippocratic method. Right? Do you guys know this one? Patient's lying on the floor, right? Patient's shoulders out. You put their foot in their axilla and yank it back in. That's high risk for an axillary nerve injury, right? But this was the historic method from Hippocrates to put your foot in their axilla and yank. Okay? Now the other one I want to tell because I'm Canadian, and that's the Eskimo technique. And so when you're out hunting for seal like we do, and you're paddling, right, a kayak, if you hit the wave, that can, if your shoulder's up like this, you can pop the shoulder out when it hits the wave, and it can jar the other shoulder, and you can pop the shoulder out while you're kayaking. And you're usually on an ice floe to get to the seals, right? But the bears, the big white ones, are also there looking for seal, and they can't tell the difference between the seal and me. I'm just the big white seal. And so if you're lying on the ground, you're usually hunting in a party of 2. If you're lying on the ground and your shoulder's out and you're 20 miles to get home, how are you going to get home with this shoulder out, right? And so the Eskimo technique was that your partner would just pull up on the shoulder, okay? Pull up on the shoulder and let your body weight dangle. But if that didn't work, you would step over them, put your foot on your chest, and then pull them up. Now, if it's getting an axillary nerve injury or a fracture and being eaten by a polar bear, we'll make a shared decision. What would you like to do? Would you like to be eaten by the polar bear, or would you like to go home today with a bum shoulder? And so that was the Eskimo technique. Please do not use that. All right, posterior elbows. Those are tricky. I actually just saw one recently. They don't happen that often, but how are you going to do it? Usually you need procedural sedation. These are bad. They're out and they're really, really painful. So the one technique and the traditional technique and the way I was taught was to have that patient lying on the bed, right, lying on the bed with their arm over the bed, one person going like this on the electronon back here, and another person yanking down, right? And they're just like this. The newer technique that I like is where you just lock hands. So you lock hands with the patient, your elbow is in their antecubital fossa, and you pull up. And it creates a fulcrum between your elbow and their elbow, and you pull up gently, and you pop it back in, and you look like a Jedi Master. These aren't the droids you're looking for. All right, so it's a really nice way. You just clasp hands, as you can see him doing there, and you just bend your elbow, and your elbow, of course, with the length and stuff like that, within their elbow, creates a fulcrum, and you can pull it up and over like that. Again, you have to be really careful about neurovascular injuries, and the big one here is the ulnar nerve, right? The ulnar nerve. So you've got to be careful. You can get a coronoid process fracture, and when it's dislocated, when the elbow is dislocated, you won't see it on the lateral. You can't see the fracture, and it only becomes apparent when you've put it back in, all right? And so just make sure you do a good, 3 nerve exams, sensory and motor. And we talked about the T-drinking nerve, the median nerve, the radial nerve, stop, or I'll say stop again, and the ulnar nerve, which does interosseous muscles, okay? And then the sensation is easy. That's median, radial, ulna. You document that they've got good sensation in their 3 nerves, okay, before you put this back in. This is just a little flow sheet to show you whether or not it's going to be unstable or not, whether or not it needs surgery. That's fine. All right, let's talk about hips. All right, hips. All right, the knee hits the dashboard. That's one classic example, all right, of the hip going posterior and getting a posterior dislocation. The first hip dislocation I saw was on about a 350-pound individual riding a motorcycle, and they dropped their motorcycle, and they ended up dislocating their hip posterior. And I'm going to show you the technique you shouldn't use to do that, to put it back in, because that's what I did. So learn from my mistakes early in my career. All right? The most common reason I'm seeing someone with a dislocated hip is what? They've had a hip replacement, right? And they bent over, and they pop out the hip posterior. So that hip is a little loose because they try to get the right leg length, equal to both sides when they're doing the hip replacement. I mean, they're cutting off the head of the femur, they're putting in a stem, right? They got the ball on there, they sit it in the cup, right? And they try to get it so it lines up, but every once in a while, it'll be loose. They'll bend over, they pop it out. Before you put in a total hip replacement that is posterior dislocation, I would suggest you give orthopedics a call. Give them first right of refusal. It'll be really helpful for your documentation in case any poop hits the fan. But also, I have to tell you, in my experience, which is dangerous, but in my experience, every time I've called up an orthopedic surgeon, said, hey, Mrs. Jones is here. The hip you did 3 weeks ago? Yeah, she bent over and it's popped out posterior. Do you want me to try to put it back in, or do you want to come in? What do you think they say? Oh, give it a try, Ken. Let me know. Okay? So they usually are pretty good about saying, no, you go ahead, right? But sometimes they'll know, because they've been in the operation, how well that cup sat in the acetabulum. And they might have some nuanced information for you, but give them the right of refusal. Phone them first before you put a total hip replacement back in. All right, so here are the techniques. There's one old way that I checked, and that I used. That was the Alice technique. And they're showing it there with the person standing beside the bed. But the true Alice technique is the gurney is here, and then I step up on the gurney, on top of it. Look, don't hit my head. I bend over and put both arms around, or one arm around, and then do gotta watch my back, and then just do a deadlift like that. Okay, and what happens? High center of gravity, and the bed does what? Funk. Explains a few things, doesn't it? Yeah, so it's a dangerous way to do it, by standing on the gurney. In that case, I had the person, because we were having so much trouble, and he was a very big individual, putting them on the ground, just on the ground and standing on the ground, so at least I wouldn't hit my head and flip the gurney and put the hip back in. The other one, that Stimson technique, do you see that one? That's in the middle. Right there? Don't you think that's a dangerous position to be in? I am not liking that person. Oh, yeah, that's in, doc. No, thank you. Okay, so that could have been me 20 years ago trying to do this. And that's what you're sitting there in your scrubs and you're like, oh. I'm going to show you two much better techniques. One of them looks like this. Anybody know what that was? Yeah, my Captain Morgan. I was going to bring a patch just to wear it for this one, but forgot it. Yeah, so there's the Captain Morgan technique. And so you put your foot up on the gurney and under their knee, right? Their knee is over top, and you can hold the foot here, right? And you push. And that acts as a fulcrum, and you pop it back in. The only thing about, I got bum knees myself. I've had too many surgeries on it, and sometimes, because of the height, the stretchers won't go all the way down. The inpatient stuff goes all the way down here for falls risk, right? But the ones that we get in the emergency department are really high, and they won't go down that far, and I have to get a CPR stool out to get my knee up high enough to do that, and I'm just worried that I'm just going to go floom. So there's the Whistler technique. And I like the Whistler technique. The patient is lying down, their dislocated hip is there, my back is to the patient, and you go under and over. And you go under and over like this, my back's to the patient, they're lying this way, put my hand on their foot, under, over, and all I do, like when I'm down like this, and all I do is do a gentle lift and push down. And I've got the fulcrum here. And again, I can show you that technique if you want during the break, because it's kind of a hands-on thing. But again, it's just steady pressure that's safe for you and safe for the patient. All right, and now we have a big toe. Now, most of the time we don't get that worried about toes, but big toes are what you're going to push off on, right? And so you need it for proper ambulation. And so if you've got a dislocated big toe, we like to get that back in, and they can be a bit tricky. These small little stubby toes, right, can be hard to get a grip on, and if they're a little wet and stuff like that, and it's like, ugh, you know, how do you get purchase to be able to do that? Sometimes you can put sticky tape around it, all right, and get that on it, and you need to often exaggerate the dislocation and then pull back and down. So you exaggerate the dislocation, pull, and then down, and that brings you up and around. And there you can see it on the lateral, seeing most of them are dislocated dorsally. And that's it for dislocations. Thank you very much.